Economic evaluation is an approach we use to assess the value for money from new health technologies. The particular way we approach these studies is to compare the additional costs of the new technology compared to current standard of care with the additional benefits. The measure of benefits we use is called the quality adjusted life year, which is a measure that incorporates the gains in survival from the use of the new treatment with the gains in quality of life. Cancer drugs represent a very important group of new technologies in healthcare. They're often very expensive, but also very innovative, bringing obvious benefits to patients. These raise a lot of challenges in assessment because they're very expensive, and we need to demonstrate that they generate gains in survival or improvements in quality of life. One of the difficulties we have in these studies is modelling the additional survival gains, because the clinical trials only last for a period of time, but we need to project these gains over the lifetime of the patient to estimate the full quality adjusted life years. Another problem in assessing cancer drugs is that the clinical trials often use endpoints that are not the final endpoint, such as survival, but surrogate endpoints such as a biomarker or progression-free survival, which is a term used to suggest that the patient is getting worse but may not yet have died. Another problem with the studies is the use of crossovers, where, because for ethical reasons, we allow patients to cross over to the active therapy once it is shown to be preferable to current standard of care. The problem with the crossovers is that essentially everyone ends up on the active therapy, so we dilute our possibility of assessing true gains in overall survival. The studies are increasingly used in decision making in healthcare. One of the critical features is to set a threshold of acceptable cost effectiveness in a given country. For example, in the United Kingdom, our National Institute for Health and Care Excellence uses a threshold of £20,000 for each additional quality adjusted life year. We also have a special criterion for drugs that are used at end of life, where the committee that makes the decisions can accept a higher threshold by increasing the value of the QALYs at end of life. There are other common problems with cancer drugs, such as the fact that they're used in multiple indications and the value for money in each indication may not be equivalent. Some have targeted through the use of an accompanying diagnostic to make the therapy more personalised, and generally we have concerns about the overall affordability of paying for these new innovations.